Okay. Yeah. So just get started in a couple of minutes. Okay. And I think we'll get started because we've got quite a busy agenda, as you can see from the screen. So let me just introduce myself. So I'm Stephanie Gatti. I'm one of the Chief Pharmaceutical Officers Clinical Fellows working within the Transformation Directorate at NHS England and Improvement. So I help to co-edit the Masterclass. So this is our Masterclass for April. We've got 3 speakers, as you can see from the screen. So we've got Sarah Thompson and CCIO from Stockport. We've got Connect Care, and we've got Tiago Rava representing Connect Care, and we've got Dr. Alistair Bishop from NHS Greater and Glasgow and Clyde. So I'll get started and introduce Sarah, who's going to be our first speaker for today. So Sarah is our Chief Clinical Information Officer at Stockport NHS Foundation Trust. She's also a pharmacist and was also one of the faces for the NHS app back in 2020 as well. So I'll let her introduce her subject, which is on digital clinical engagement, which everyone's going to find really useful for today. And if you have any questions, please pop them in the chat and I'll ask them afterwards. Okay, I'll hand over to Sarah.
Thanks, Steph. Can you hear me okay? We good to go? Yeah. Fab. So happy Wednesday all, and thank you for welcoming me to chat to you today. So I'm here to talk about some research I've undertaken, particularly in relation to digital clinical engagement. Next slide, please. So I'll start by introducing myself for those of you who I haven't had the pleasure of crossing paths with yet. So my name's Sarah Thompson. I am a clinical pharmacist by background. I've got over 11, 12 years experience now in the digital side of the NHS. And as Steph alluded to, in 2019, I was one of the clinical faces of the NHS app. I was pregnant at the time, so I helped promote some of the useful features at that point, not realising, I guess, how its use would explode over the preceding 2 years once COVID hit. And the smart picture there is one that was used as part of that promo. And the table that I'm actually sitting at is hiding my 6-month pregnant belly at the time. So yeah, I've worked on a number of digital projects, mainly in the NHS. I did venture to the supplier side for a little while, which has given me great perspective on how things work on the other side, and also some of the challenges that our colleagues as suppliers face as well. My current role is that of CCIO at Stockport. I am the sole CCIO covering all of our digital clinical systems, but I've got a great multidisciplinary clinical team supporting me in doing that. I'm a huge advocate for the non-medical CCIO roles, and I'm actively participating in pushing this agenda in every possible way I can. I do believe there's a multidisciplinary approach needed for the office of the CCIO, but that's not what I'm here to talk about today. So background to my project was I was one of 4 pharmacists on the very first cohort of the Digital Academy, and I continued that to study to the MSc level. My dissertation was titled on screen there, so it was developing a clinical engagement strategy in a challenged and pressurised workforce. And today I'm going to talk you through the factors that research came out with in how to approach clinical engagement. Next slide, please. So the first thing to consider really is defining what we mean by engagement. And we also need to consider what engagement is not as well. So a reasonably simple definition of clinical engagement in the digital setting is the active involvement of clinicians to ensure the needs of both end users and our patients are met in the design and implementation of health solutions. So it's then the application of this knowledge and experience that forms the richest engagement, ensuring that our digital solutions are really fit for purpose. It's really easy to think that we are engaging with individuals and teams by communicating with them. Yep, communication is a huge essential part of the process, but it's not. It's a single part of an active engagement relationship, and really we're looking for a more meaningful collaboration between leadership and the wider workforce. So in applying this to digital, I guess it's fair to say that meaningful engagement is a critical success factor to effective digital transformation. The NHS long-term plan laid down a foundation that digital transformation is a core requirement for the NHS. So that detailed how digital services should enable delivery of optimised care processes, but also that we need to recognise the operational pressures on frontline staff. User engagement and involvement is a key principle at the heart of the WACTA report from 2016. In there, WACTA referenced user-centred design, workforce development, adaptive change, all core parts of engagement. And finally, the Topol review further emphasises, the criticality of prioritising user engagement, detailing it as it was detailed as a prerequisite for technology-enabled transformational change to be successful. So the background information is there as to why engagement is so critical. And my research was really how do we go about putting in a strategy for engaging with our end users. Next slide, please. So to set the scene for you in relation to the context of my research, Stockport is a relatively digitally mature trust. In 2019, following 3 years of intense activity and successful clinical engagement, the trust terminated an EPR programme. We actually pulled it a few weeks before go live. It was quite a big decision to make at the time. Following this, the organisation regrouped. We commenced a programme of optimising our existing systems whilst exploring what the future would look like. And the aim of my research really was to assess levels of understanding of engagement across the workforce in the aftermath of this EPR termination decision, in order so that we could regroup and look forward to how we could re-engage with what was, quite frankly, a really disillusioned workforce with respect to digital programmes. My data was collected through a survey and a number of in-person interviews. And following review of the findings, we've made some conclusions, and proposals were made in the form of almost a blueprint, really, some core components of a digital clinical engagement strategy that could be applied to other organisations. And this offers guidance, methods, considerations, and some best practice to organisations who are looking at a new or refreshed digital clinical engagement strategy. And that's hopefully what I'm going to briefly talk you through today. Next slide, please. So the key findings, before I move on to the sort of blueprint, they came under 4 main headings. So an overwhelming discovery in both the survey and interview was the continued negative perception of clinical IT programmes at our trust following the EPR termination. There was a clear lack of understanding of strategic direction for digital at the trust, and this really limited engagement opportunities. Staff didn't know what the strategy was. Secondly, there was a need for continued and extended credible leadership to continue to encourage and ensure successful engagement, and partnered this was raising awareness of the CCIO role. At the time, our CCIO was the former medical director. Great engagement with the medical staff, but actually we needed to make sure that was widened to the whole multidisciplinary team. An interesting concept that emerged was the need to use smaller projects and use benefits from those smaller projects to earn engagement. So clinicians described the desire for instant gratification. They wanted kudos, they wanted credit for changes that were being made, and they felt that this was a way of almost earning their engagement. And the extended timescales of previous IT projects were putting up barriers to staff getting engaged. So we've taken a more sort of small step approach now, in that we'll try and get individuals involved in smaller projects to try and sort of demonstrate to them the benefit of working with us. Finally, ensuring staff have a clear understanding of why they're engaging. So we need a clear feedback loop. We've also implemented the concept of a digital champion role to help create a network of connected and up-to-date individuals who've got a sense of ownership and responsibility towards system development. Now that's still in its sort of starting days, but we're starting to make those links across the organisation, and I think that'll make a real difference actually as we start to embark upon an EPR again in future. Next slide, please. So we've covered, there's a blueprint, as I say. So from the findings, we've come up with this 10-step template approach to how to develop and implement a digital engagement strategy. This isn't saying this is how you do it. This is just a sort of example of some best practice that could be taken and tailored to individual organisations. I've tried to keep the information on screen as sort of clear and concise as possible. We've split it over the 2 slides, but these will be available afterwards as well. So firstly, undertaking a background and readiness assessment. So understand why a digital engagement strategy is required. So asking questions like, why is this new strategy required? What is the status of engagement at the moment? What's gone well in the past? What could be done differently? What sort of appetite is there for engagement at the moment? This will help enable an understanding to launch any new initiatives from. And it also feeds really well into the next steps where organisational context is determined. So consider launching a survey or some feedback events, focus groups, interviews, open forums, and that could help measure current status and identify needs. Second is around organisational context and alignment. Several themes to consider under here. Organisational strategy being one. So where does digital sit within the current trust and organisational strategy? We're really lucky that digital is listed as a key enabler for everything within our trust strategy. So we know that digital's got the recognition that it needs there. So consider any sort of contextual information for the organisation. Has there been delays or issues with previous programmes? And is there a clear and published digital vision and strategy? And at the time I did this research, we didn't have that. And it'd be interesting now that we have published our strategy recently to see how that's changed. Operational status and context. So what other strategies and initiatives may impact on staff buy-in? So is there some sort of major restructure planned? Have lots of changes been recently introduced? What could impact the effectiveness of new changes? And this also affects the operational culture and ability to implement any change as well. And obviously, whenever we talk about engagement, it would be remiss of us not to mention the impact that operational pressures and limitations that can have on staff being able to successfully engage in these programs. Organisational leadership buy-in is key. So are the senior leadership sufficiently engaged in digital? So does this include the chief nurse, the medical director, the CCIO team? And is staff engagement a priority of these individuals? Do they see the benefit of it? This section leads nicely on to point 3 around the SWOT analysis. So using the information gained from steps 1 and 2, coming together with a SWOT analysis to understand the current context and status. So this allows the organisation to effectively plan, so play to their strengths, be aware of their weaknesses, exploit opportunities and manage the threats in any future strategy. And really this forms the baseline current position from which you can then benchmark to prove benefits later. Next is around objectives. So an effective strategy always requires clear and concise objectives in order to demonstrate and measure success. Really, these should be set out in SMART terms. And in terms of objectives, really, it's important to remember ensuring staff understand the importance of engagement. Do they know what the term means? Do they know what benefits they'll get? Set clear definitions for engagement and expectations. So could you have some short-term goals versus long-term? And this is also a good time to undertake some stakeholder analysis. So who are you aiming to engage with? And remember those junior and non-clinical staff groups, but in the context of why you're engaging. So if engagement is to develop clinical workflows in systems, you're going to need individuals with appropriate seniority and autonomy to authorise. However, getting ideas and sort of inspiration for development can actually quite often come from more of the junior members of staff, and just consider that wider user base as part of any engagement strategy. Fifth is around options. So determine what structures and opportunities are in place to already engage. So any quality improvement initiatives, existing forums. Could you use something like the digital champion, ambassador type role, and what commitment is required to achieve this? And remember at this point to consider any of the operational pressures from your SWOT analysis to work around or work with these. Next slide, please. So continuing on through the cycle, step 6 is around strategies and initiatives. So understand why the strategy is required. And this is a time to take some detailed planning based on the options. How can you measure and demonstrate success? Use data, case studies. One of the things that one of our consultants kept saying was, I just want data. Use the data to prove to me why I need to get involved. And actually that's sometimes quite a big win. And as we spoke about, consider using smaller projects to earn that future engagement and trust from the staff. And identify, I guess, how to demonstrate the possibility for improvement. So demonstrate how you're going to prove that engagement is worthwhile. You know, people want that gratification. 7 is around timeliness and resources. So using the strategies and initiatives from point 6, ensure that you've got a realistic timeline of activities and anticipated resources. If we're asking for staff time, we want to make sure it's used effectively. Provide some milestone target dates and strategies to implement with that. Number 8 is around governance, structure and accountability. So this applies to the wider organisational governance. So what reporting channels are there? Promote the CCIO and you know, associated roles, and clearly identify who's expected to do what at that point. Sorry, I think my slides might have got confused here, but we'll keep going. Number 9 is around communications. So although comms only form one part of the engagement process, we need to make sure that they're aimed and planned correctly. So ensuring there's a formal communications plan in place, ensuring that you work with the local comms team to identify how they can support, and ensure that you use the previous identified stakeholder analysis to cover all stakeholders. And finally, number 10 is around feedback, evaluation and replanning. So this is the most important step. So once you've planned out all this engagement and got the staff on board and have strategies for using them, actually, once the process is done, that's not finished. So you need a clear and effective feedback loop for staff to input to future development. So as well as ad hoc feedback, identify any metrics or assessments that can be undertaken and seek that feedback. And in the diagram that I'll share with the slides at the end, you'll see this actually gets painted as a bit of a picture of a loop. So the whole 10 steps start again. So next slide, please. So to summarise, I guess what my key points to get across, the key headlines I want to get across to you is you need to understand what engagement is and what it is not. You need to appreciate the purpose of engagement in relation to the trust context and strategy. Do some background work to assess the current position and current feel of the organisation. Have a clear strategy and approach for engaging. Recognise the challenges and adapt the approach. Be adaptable to how you approach that engagement and actively seek feedback. Be aware that actually articulating benefits of successful engagement, demonstrate, celebrate success is really important at being able to re-engage people in the future. And it's all part of a cycle, so keep re-evaluating. No two projects are the same, and it might require an adaptive approach. And yeah, it's hopefully something that can be applied across different digital implementations. It's not specific to EPMA or to necessarily digital innovations, but actually we're hoping that this is something that can be used as a blueprint for organisations to take a step back and evaluate how they are approaching their engagement. So thank you for listening today. I hope it's been useful to you all. I will make sure that second to last slide gets updated before they get shared. There's some, I think the notes on the slides weren't quite right, but I'll make sure that's updated.
That's great. Thank you, Sarah. Thank
Thanks.
you. It was really informative. It was really, really informative. And so I've got one question before I go to our next speaker.
Yeah.
So you have said at the end about this is not necessarily strictly for digital programs specifically.
Yeah.
Where else do you see this being used across, say, national or ICSs?
So obviously my focus has been on digital programs, but actually I think a lot of this could be applied to any transformational change. So whether that's just process change, whether it's general staff engagement. The focus obviously was on digital, but I think there's some concepts in there that if we are looking to engage with staff to, I don't know, introduce new ways of working or new strategies within the organisation, I think there's some ideas in there that could be used, because as you can see, it isn't very specific to digital. Yes, there's references within that, but hopefully it's some food for thought for other programs.
No, that's great. Thank you, Sarah. And I know we've got a busy agenda, so I'll move on to our next speaker.
Great. Thank you.
Okay. Thank you. So our next speaker is Tiago Webber from Connect Care. So the reason we've got Connect Care on, so they're an organisation, a company looking at social care and looking at how to improve how things are displayed within social care. Am I right, Tiago?
Yeah.
Yeah. And so I would just to give you a bit spiel as to why we're introducing them. So we had a recent hackathon at Rewired. So that's where we bring suppliers and companies together to basically come together openly to solve a problem. And Connect Care helped us with a problem, and they're going to explain a little bit more about what happened at the hackathon.
Yeah, hi, I'm Tiago, and during that hackathon, so first of all, Connect Care is focused on building tools and APIs around medication and pharmacy in general. So we're trying to solve little problems and together find a way for pretty much medication information and adherence information to flow to the right people. During that hackathon, we were just partnering with a couple of companies and trying to solve very specific problems over a course of 2 days. So next slide, please. So we worked with LogMyCare and Anthropos and person-centered software on 2 different projects. So with LogMyCare, we provided them with dispensed medication information so that they could populate their EMAR, the medication administration records, within their care management software. And the talk I'm going to be talking about more today, the hack we did was about Anthropos. So with Anthropos, we made sure they had some, not just the dispensed medication, but also some insights that will help them work on false risk index and make sure that the information would flow all the way to the carer. So this is all about making sure information would flow. Next slide, please. So why were we there? We've been attending the Interopen hackathons, the last 2, and we've been trying to get more and more involved. So one of the things is the ability to strengthen the relationships with these companies and with the professionals that are there. So one thing is for us to talk about how data could be used and how we could do something with the information we already have, but it's only by trying it out very quickly that we kind of find the pain points and what works and what doesn't, and how we should better prepare that information so it's easier to consume by these companies. So these hacks are super valuable for us because they give us that level of insight. We already knew Anthropos and LogMyCare, and we invited them to the hackathon, but we've found a lot of details about what wasn't working and how we could optimize that information transfer just by doing the hack, which was great. And the other part is just knowing more people that are directly involved in these open standards and FHIR, and to understand how to better leverage those standards and how to make this information available. So next slide. Thanks. So The title of our project was Closing the Loop on False. Next slide, please. We were trying to find a way. Well, Anthropos did some research, and they have a product they're trying to release about calculating false risk index. And we know that medicine information and drug information was a big factor for that calculation. So we wanted to make sure that it could have that information in near real time. So whenever something was dispensed from a pharmacy, we wanted that information to flow through their systems. This is something that's kind of difficult to do because the information is available. The APIs are now becoming more and more available and easy to access, but there's still islands of information that we need to collect and to provide in an easy to consume way. So next slide, please. So it was all about kind of closing the loop between the pharmacy side and the remote monitoring and false prevention side, which is Anthropos. Next slide, please. So the first thing we did was we came up with fake patient profiles. So you're looking at Kelly and Anton. We had to do basically think about what medications they were on and have the full medication profile, inject those prescriptions into the system and making them available. Actually, Kelly and Anton are also the names of the two developers that were working on directly on this hack, and this is how we imagine they're going to look like in the future. We can move on, please. So looking at Kelly was the profile we came up with is 103-year-old female living in a care home. She has never had a history of falls, even though she uses mobility aids, and she's currently taking 4 medications for long-term conditions. Next slide, please. So something has changed, and we did this demo live during the hackathon where we just said, okay, something changed, there's a new prescription. And so Kelly now went from 4 medications to 5, so she's now at the risk of polypharmacy, which is one of the leading risk of falls. The whole example here in the whole scenario is just making sure that this information could flow through the system, that we could turn the available information into actionable insights that the carers will have directly on the tools that they currently use. Next stage, please. Next slide, please. So how was this happening exactly? So the medication data enters the pharmacy software that flows through our system, and Anthropos picked it up on their system, and they created a care node with the updated false risk index calculated. That care node was immediately made available to the carers on the handover nodes, and that was our main focus, trying to understand what are the bottlenecks and what are the difficulties in making sure that the information that's widely available can actually flow through the system. And this was very successful in identifying some of those and fixing them and make sure that it would flow. Next slide, please. So this is just information about how they're looking at the false risk index. So Anthropos did some research with lots of scientific papers, and they found there's around 400 contributors to falls, and they're now focusing on the top 40. From those, several of them have to do with medication and medication details. Next slide, please. So when we look at drugs as a factor, and what we're trying to do is provide insights to these companies and not just provide the raw data, which we also provide, of course, but we look at these drugs as 2 things. Either they're an influence because the drug itself, actually because of the adverse reactions or some of the properties of the drug, will contribute to an increased risk of falls, or we look at them as an indicator. Maybe they can tell us that there's an underlying medical condition, and because if a drug is usually used to treat a UTI, that would be one of the factors that they identify as being having a high correlation for an increased risk of falls. This is one that we haven't done yet. It's kind of difficult to achieve, which is how do we get access to the actual underlying medical conditions that the patients have, and how can we at least have a weak link between the drugs they're taking and those conditions, so we can then influence that this drug is usually used to treat a specific condition. But looking at the full profile, we're fairly certain that that's actually what's happening here and not something else. That's one of the challenges we have moving forward. Next slide, please. So again, this is all about making sure everyone in this process will benefit from data flowing. We're getting out of time, so next slide, please. Can you go back, please? Oh yeah, sorry, next slide. So where do we go next from here, right? So the next stage we're looking at, and this was a very successful hack, and it proved that we can actually make the available data and use the available data and turn it into actionable insights. We're looking at what else are we missing, right? So one of the issues is that we don't have a full overview of all of the medication records that we have. So for instance, we need to get data from trusts, and these patients are coming in and out of hospitals. So we will need to pull data, which is already available, and to create a unified medical record, which also includes the information from the pharmacies that we're working with. We also need to get the administration information, right? Knowing that someone is on a specific drug isn't enough to us. We need to know if they took it on time, and use that to try and find a correlation to what actually is happening with the patient. So the project we did with Log My Care was actually that, trying to get the information for the medical administration record back into our system so we can provide insights. And the other thing is to provide, again, insights, not raw data. Make sure that we don't make it difficult for our partners to process all of that. Make it as easy as possible for them to be able to ingest that data and to then produce the notes and the information for the carers to act upon. And that's it. Next slide, please. So if anyone has any questions, by all means, we're available to answer.
Hi, Tiago. Thank you for that and giving us insight. We don't normally have companies and suppliers, but this is just to give you insight of how we're using the standards that we've got. So using necessarily how we can push the standards, fire standards, DMD, how we can push it forward, and how it's not just within hospitals, but how it interacts in the wider context and in social care, where most of our medicines are taken by our patients. So one of the questions is, how do you think hacking, or how do you think hackathons can help with the NHS push forward with problems that are being identified?
So we became very, very much interested in doing more hackathons, because the challenge these days is not just that it's technically feasible to get that data. It's not that. It's how do you make sure that the companies operating in social care can actually use that data for something actionable, right? How and the best way that we found to identify those bottlenecks was actually to be on those hackathons, to actually play around with things and to have product people, not just technical people. Actually, there were product people there, and having discussions on how can we cross-check all of this information. There's a huge amount of data available these days, and the big challenge is, how do we cross-check all of that? How do we make that useful? And it's very difficult to develop these programs without having. And the last talk was about engagement. This is actually the problem. How do we engage the companies and the people operating, which is mostly in the private sector? How do we engage them to work closely to the NHS? How do we make sure that the information we have available can be exposed to them, and how do we make sure that they can actually use that information and then feed back to the NHS, which is one of the problems we're still trying to figure out, is how can we then pull this data back. So hackathons are really, really good ways of us to get quickly to a prototype and to an idea and see if that idea actually would be good enough to then be turned into a real thing. So yeah, we're wanting to do more and more of those as a way to avoid lengthy sessions of discussions and just try things out.
Yeah, I think that's a great way. Hackathons are great ways for people who wouldn't ordinarily meet and be able to discuss openly, whether that be virtually or in person. So another thing I wanted to ask was about social care specifically, and the uptake of standards and how important that is, like you said, for information flow.
So that's one of the challenges we have now, right? Open standards are great because that means we can pull data from multiple systems within the NHS, and we don't have to do one-off integrations all the time. For smaller private companies operating in social care, there's still quite some work to be done to make sure that they have the right tools to be able to pull that information. Why are we thinking that one of the solutions for that will be to build specialized tools and APIs that make it easy for them to consume data without having to go through the whole process of implementing an open standards, and then slowly evolve once these standards are more mature, because they're fairly recent and FHIR is still very much in active development. Then we think we can slowly help these companies operate over open standards. But the main benefit for us for having those open standards is just making sure the data is now available, and that companies like us and other companies that have a bit more time to focus on that problem can then, pulling data from all of the trusts on the medication record would be very, very difficult to achieve for the entire country if we didn't have standards like this one. We just can't expect companies, small companies operating on social care, to do that investment yet. I think that will come with time once the standards mature.
Okay, thanks. I think this is a good use case for why we have the standards, and so that we can operate in a world where no one gets left behind, as per se, and that everyone is able to manage their medicines, and that we have an open flow with medicines information. Thank you, Tiago. So I'll bring us to our next speaker. So I'll introduce our next speaker, which is Dr. Alistair Bishop. He is the eHealth SDPN for Safer Medicines within the eHealth Directorate at NHS Greater Glasgow and Clyde, and he's going to do a presentation looking at the lessons learned from implementing an EPMA system at scale and pace within Scotland. I think this is going to be a really interesting talk, and I think there's lots of lessons that we can gain from this. So I'll hand you over to Alistair.
Thanks, Stephanie. And Sarah Black, I think you're going to give me keyboard control if that's possible.
Yeah, you should have it.
Fantastic, thanks so much. So hello everyone, I'm Alistair Bishop. I work in NHS Greater Glasgow and Clyde, and I'm going to talk to you today about our experience implementing electronic prescribing at scale and at pace. So I'll just move on with my slides. There we go. So first of all, I'll give you a little bit of context about the organisation I work in. As you can see from the picture, it's always sunny in Glasgow. NHS Greater Glasgow and Clyde is a territorial health board in central Scotland. It's a bit like a trust, but it includes acute mental health, primary care, community and GP all in one organisation. We're a very large organisation. Some of the key numbers there will show you that, but we have 500,000 ED attendances a year, over 1 million outpatient appointments, and so on. And from an EPMA perspective, we have 9 main acute hospital sites, around 6,000 beds, also a number of inpatient mental health sites, and so on. So we've got some challenges in terms of the scale of the organisation. So why do EPMA and why do it now? Some of the answers to that question are kind of illustrated there with a picture of the Cardex, the paper drug chart, but there were a number of specific benefits we were hoping to achieve. Primarily safety. There's good evidence from elsewhere that EPMA can improve safety or reduce risk in a number of aspects of medicine's practice, and also some evidence that certain parts of the process can be made more efficient. Thinking more strategically, we are very interested in moving beyond islands of data, like Tiago was talking about, to have a much more joined up, integrated clinical electronic record. And increasingly for us, inpatient medication information was a missing piece in that jigsaw, and the next step for us to take in our move towards increasing our digital maturity. There's also a number of strategy and policy drivers in Scotland, similar to the rest of the UK, for introducing EPMA. All NHS boards are expected to do so, many already have, and there is central funding attached to that. So lots of other strategic reasons why we wanted to do this. So how did we go about getting ready to introduce EPMA? And I think the most important first step was coming together with a realistic business case. In other words, we thought really hard about a scope. So how far within the board do we want to introduce EPMA? How long can it take? Must it take? Therefore, how many people do we need to actually deliver on time? What approach is going to work best? And as I said earlier, what will it give us back? What will the benefits be? So scope was a really important decision for us to make, and broadly EPMA, or EPMA as it's called in Scotland, replaces the paper drug chart. So anywhere there's a traditional paper drug chart in use, we'll move to using EPMA instead. And that really means, at least for our initial implementation, wards and theatres. We have around 330 wards and about 120 theatres, and we expect by the time we're fully rolled out, probably around 18,000 users of EPMA. So the decision was made to pilot and then rapidly move on to rollout, and to roll out across all 330 wards and 120 theatres in an 18-month period. So we then had a lot of building to do. We had to, first of all, build a team of people to introduce EPMA. And although part of that is a technical task, most of it is an engagement and a clinical change task. And thinking back to what Sarah was presenting on earlier, very much a lot of the same lessons for us. How do we engage with our nurses, our doctors, our pharmacy staff, and bring them on board, get them on side, and make them part of a successful implementation. We did also need to build the system, so there was a lot of work to pull that together. And also we had to build momentum and goodwill, and that's about engagement, about communication, about telling clinical teams this is coming, this is what it will mean to you, this is what will be different, this is what will be better. And finally, we also built very much on what others had done. So we borrowed liberally from what some of our neighbouring boards had already done, so we weren't starting from a blank sheet of paper. Governance has been really important for us too, getting the right people around the table. For quite a long time, we've prioritised digital safer medicines practice, and we have a kind of mature governance group in place already, which includes nurses, doctors, pharmacy, service management, staff side, and e-health. And under that, we created a HEPMA programme board and a number of sectoral oversight groups and weekly operational meetings with the wards that we're about to go live each week. We go live in about 8 to 10 wards each week, so that's very much a rotating cast of people attending those operational meetings. Really important point, all of our key governance groups are chaired by clinical stakeholders. So our HEPMA programme board is chaired by one of our medical directors. Our sectoral groups are chaired by the chiefs of nursing for each area. And that's been incredibly important in getting that buy-in, that engagement clinically as well as strategically. And we've been very keen to position EPMA not as a e-health project, not even as a pharmacy project, but as a clinical project. The groups of staff who are most affected are nursing and medical staff. So just a quick illustration there of some of our key governance groups. I won't labour on that, but important to say that the programme-specific groups we've put in place exist alongside our pre-existing medicines governance structures, and we've got very close links there. So, big organisation, there are some positives to that and some challenges. Positives, we've done other big implementations before, so we've got a lot of learning on what works and a lot of learning on what doesn't work, and that very much informed our approach with EPMA. And we have a degree of leverage with suppliers because we're quite a big customer. On the other hand, because we are large scale, we needed to implement much more quickly than has been done elsewhere, at least in Scotland, because if we were to go at the same pace as some of our neighbours have gone at, it would take us 5 to 10 years to roll out completely, and clearly that wouldn't be acceptable. Also, we've found before, and I'm sure we'll continue to find, that when we bring in a new computer system, it kind of stretches it in terms of what scale the system can cope with. So we often have to make adjustments or get the supplier to make adjustments to cope with lots of patients, lots of users, lots of wards. We also have a lot of very high acuity wards and a lot of complex and highly specialised services, both regionally and nationally. Okay, so how did we go about actually implementing? I think we made a number of key decisions, some of which were kind of counterintuitive or different to what we would normally do. And I think it's important to talk about those. So I've already talked about the importance of clinical ownership and leadership across the entire programme. Really important that we have enough resources, enough people to actually provide the support we're going to need to provide so that nurses, doctors and others can confidently use the system. And that business case stage I talked about earlier, not the most exciting topic, but really important to secure the money required to bring together a big enough team of people to support the clinical teams. We don't do classroom-based training. At the best of times, getting nurses, doctors and others released from clinical duties to attend classroom training is pretty difficult. And the last 2 years have obviously not been the best of times, and it would have been impossible for us to get a lot of people to classroom-based training. So instead, we ask all of our users to complete e-learning before they go live. And then my team of facilitators is fully deployed on the clinical floor, in the wards, in the theatres, providing direct support, retraining if required, to the clinical teams. We quite quickly learned that although that support is extremely important, it wasn't needed for as long as we expected. So we'd originally planned to support every ward for about 2 weeks. Very quickly, the teams on the wards were telling us, look, it's the first 2 or 3 days that are really important. That's when we really learn the system. So we've actually reallocated the resource. So we now give each ward a shorter but more intense period of support, which means we can have more of my team on the floor for any given ward. And we've had really good feedback that that works much better for the wards. We also had to decide what order to go through our sites and actually implement the system. And this was a very contentious discussion, but in the end we decided to start at our biggest, most complex, highest acuity site and work our way down. Number of reasons for that. First of all, although it front loads the problems, it means your first few weeks are quite difficult. It means you very quickly encounter most of the problems you're going to, find solutions, and that makes the rest of the rollout simpler. It was also really important in building trust that the system is going to work. So when we got to our second big site and we were discussing whether to go live during COVID peak, one of the consultants there said, well, look, if they can do it at the Queen Elizabeth, we can do it here. And that was really useful, having already been the biggest site on, in the board. And then in terms of within each site, what order do we roll out? We found that starting at front door units and working our way in along lines of patient flow was the best way of reducing the problem of patients moving from paper to electronic and back again. You can never completely eliminate that issue, but this approach has worked best for us. So how's it gone? Currently live, actually we're now live in about 210 wards and 70 odd theatres. We have about 15,000 users. We've had 1.7 million prescriptions on the system and well over 12 million administrations. The feedback we get is users like the system, they learn it quickly, they get to grips with it quite easily. The approach we've used for support and training has been really positively received. We constantly get feedback from clinical teams that that works for them. We've got good evidence already that it's speeding up drug administration rounds, reducing missed doses, improving allergy recording. And we've also got some really powerful data about the decision support in the system. So the system will warn about interactions, about allergies, and the evidence we have suggests that every month, 30 to 40,000 prescribing decisions are changed in light of the warnings that the system is giving the prescriber. So really, really powerful stuff. What's next for us? Complete our inpatient rollout by the autumn. We're already looking at using the system in day case units. We'll then move on to outpatients, and our EPMA implementation is part of our broader e-medicines program, which is looking at making as much of our medicines practice as possible electronic rather than paper. So in summary, lots of local and national reasons we wanted to introduce EPMA. Really important to do that both safely and effectively. Large scale does bring challenges, not least that we had to roll out and are rolling out very rapidly. We've adopted a different approach to training, support and rollout order than we've done before. And the feedback we've had is positive. This approach is working for us, and we'll certainly continue to use this way of working for future programmes. So that's everything I want to cover. Thanks so much for your attention. And if we have time, Stephanie, really happy to answer some questions.
Yeah, no, that's great. Thank you, Alistair. It was a really good presentation and showing how you can implement EPMA quickly and at pace. And it's good that you've had this many prescriptions and administrations over this short period of time. So I just wanted to ask one question. Is there anything, you showed some of your lens, but is there anything that you would have changed that you didn't change earlier within this process?
Yeah, it's a great question. I mean, I talked about in the presentation, one change we made very early was how long we thought the team would need to be on each ward. So we had planned to be there much longer, very quickly learned that we could get better value by being there for a shorter time, but in bigger numbers. So that's probably the biggest thing we've changed. Probably worth saying that renal transplant was obviously a very highly specialised area, and there were some aspects of how they work with medicines that we needed to pause, tweak the system, and then go back. So that's an area that we perhaps could have anticipated beforehand. But overall, I think I'm really pleased with most of the decisions about approach that we've made, and in the main, it's worked. So I'll just see a couple of questions on the screen there. I think we will be sharing slides, Stephanie, is that right?
Yes, we will be sharing slides afterwards. So the recording and the slides will be available afterwards.
That's great. And then there's a question from Jordi. 30,000 alerts fired every month, or 30,000 prescriptions are changed. So it's interesting, we actually have about 200,000 alerts every month, and roughly 1 in 10, 1 in 15 or so are acted on and result in a change. So we are looking at 30 to 40,000 changes to prescribing decisions each month. We're currently about 2/3 rolled out. So once we're fully rolled out, it'll be a bit higher than that. So yeah, I guess it's quite a lot, but it's interesting that we're seeing that. And obviously by definition, all of those prescribing decisions would have ended up on the paper prescription without any changes. So I think it gives confidence to me, certainly, that the system is having a positive impact on practice. Gosh, lots of questions. I'll try and get through them quickly.
Yeah, there's lots of questions. I think we could probably do 2 more questions, and then any other questions, Alistair, if you don't mind, if you could answer them separately, we'll send them out and then put them on the Futures website. Yeah.
Also happy to share my contact details if people want to follow up afterwards. So I'll just quickly go through the questions that I can. How long was testing before going live? So there was a really extensive national accreditation and testing process that brought suppliers onto the national framework. That included 1,300 individual requirements, multiple days of testing with the supplier in the room. So that was really thorough. And then we did our own local testing as well. How could you see future artificial intelligence-based clinical? So it's really interesting. We're starting to look at opportunities for AI and machine learning as part of the prescribing process. EPMA gives us a massive data set to work with. So some real opportunities in terms of machine learning there. We're very early stages in terms of hooking that kind of artificial intelligence into the system. But I think in the future, that's a real opportunity. Can I be naughty, Stephanie, and answer another one?
Yeah, so I'll give you one, which is the last one that's come in, is how do you manage, which kind of brings into Sarah's presentation as well, and a bit of the Connect Care, is how do you meet the challenges from, say, tech dinosaurs, people who are not so au fait with tech and don't want to move in that direction?
So great question. We've had some really great examples where we have had staff who are not so much dinosaurs, it's just they're nervous, they're not confident with technology. And I think our approach, having our team physically on the wards with their HEPMA t-shirts, which are purple, so they're very visible, easy to ask for help. And we've had our people shadowing, working, literally standing beside nursing staff as they do their first couple of drug rounds. That one-to-one support that was possible because we didn't waste resource on classroom training has really helped people get that confidence. And what we find is once people have used the system for a day or two, they come back to us and say, you know, it's much better than I thought it was. I don't know what I was so worried about. I would never want to go back to paper. So I think getting people over that initial anxiety is really important. And certainly for us, we found that to be pretty successful.
Okay, that's great, Alistair. Thank you so much. I know there was more questions in the chat, and Alistair's kindly and said he will answer questions and we'll put them on the NHS Futures website. So I'm going to close. I want to say thank you to all our speakers today, and thank you to all of you who attended our session. This is just a reminder, if you haven't signed up already, we're hosting an event which is Transforming Lives with Digital Medicines, and this is for anyone who's involved in ePrescribing or a digital medicine system. As we know that, and as we've heard today, digital transformation is at the heart of patient safety. It's also at the heart of the recovery plan, and it's about an event to bring in a network back together for teams to share their learning and to learn from others to help support implementation, optimization and adoption of digital medicine systems, ePrescribing and the standards. The registration link is here, and we also would like you to join our mural board. So this is a mural board for you to put your notes on there to say where you are on the journey, and that's going to aid with networking, so you can find out where other people are on the journey. Are they implementing? Are they optimizing? And are they procuring? Where they are, or if you've got any problems, you can connect with others. So it'll be great if everyone could go in there before the event and just write and just answer the 4 questions that are on there, and that's to help build a network. As you know, we just want people to share their learnings and to interact with others, and that's how we move forward in transforming lives with digital medicine. So I'm going to say that's it for today's session. Again, thank you to our speakers, thank you to Sarah, thank you to Tiago, and thank you to Alistair. And the next session that we have is on the 11th of May. And if you want to be involved with any or want to volunteer yourself for any future sessions or have any ideas for any future topics, please email Sarah Black. Her email is on the screen. And if you could promote the session and hashtag and continue the conversation online and using the hashtag ePrescribing Masterclass. I look forward to seeing you all on the 27th of April at the Transforming Lives with Digital Medicines, and see you at the next Masterclass. Okay, thank you everyone.
Thanks, Stephanie.
Thank you. Thank you.